It's a wonderful turnout. Thank you. As people keep joining us, please know we're just waiting maybe 30 more seconds, then we'll start officially. All right, we crossed the 500 mark. I think that's probably good enough. I know people will continue to join, but in the interest of time, I'd love to go ahead and dive us in. So, welcome everybody. I'm very, very glad that you were willing to spend some time with us today, especially because September 30th is probably a day you have many competing demands on you, but you were willing to come in and join us live as we talk about fact and fiction and clinical suicidology and what actually works. My name is Kevin Crowley. I'm a clinical psychologist with CAMSCare, and I love doing these webinars. I love hearing from our presenter, professor of psychology at Catholic University of America and developer of CAMS, Dr. Dave Jobs. We'll just remind you really quickly that I'd like for this to be as interactive as it can be, which means I'll try to answer some questions as they come up in the chat, and I'll track questions to ask Dave at the end of the presentation. We hope that we can get as many questions as you'd like answered, and we hope that after this presentation, once we make it available to you, you distribute it to colleagues and people who you might find this helpful. There aren't any CEs for attending, unfortunately, but we do hope that the really good information you're going to get more than makes up for that. So with no further ado, I'd love to hand over to Dave.
Thank you, Kevin. Welcome, everybody. We're so grateful to have you join us today. At the end of Suicide Prevention Month, I think this is like my third or fourth major presentation. I had to be in Rome last week, which was an incredible experience. But this is very special to me because this webinar series, which we've been doing since COVID-19, the pandemic, has really been a rich contribution to the field. And we've had me over the years take a spot in September, Suicide Prevention Month, to do catch-up work on some of the work that we're doing in the Suicide Prevention Lab at Catholic U. And I'm very grateful to Kevin for hosting this webinar. Fact versus fiction is really the idea here that there's a lot of things that we do in the name of suicide prevention in the clinical lane that is done just because we've always done it that way. And what I'm going to be really diving into is the evidence and the science behind what actually is proven to make a difference with people who struggle with suicidal thoughts and feelings and behaviors. So with that, I will share my screen and we will launch into this presentation. Okay, so this is the university, and I'm speaking from my office here at the university. I've been for 38 years. I think a lot about sort of my 43 years in the field and really knowing a lot about this topic and ever coming off like as a know-it-all. But that said, I'm 67. I've seen a lot over the years, and a lot of things I think kind of keep on coming back when you do this for a number of decades. So I'll try not to be a know-it-all, but I'll try to also really share things that are meaningful to our field from an evidence-based perspective. Okay, so our there we go. These are my conflicts. I'm funded by the NIMH and IEEE, and there's a PCORI grant. Four Pines Fund in Vermont is generously supportive of my lab and my students, which I'm so grateful for. I receive book royalties from APA Press and Guilford Press and Jasper Health. And I'm one of the founders of the training company that's bringing you this free webinar series. I'm a co-owner of the Hope Institute, and when I talk about the DoD or VA, I'm speaking on myself as a citizen and not on behalf of the government. So my summer's been spent really immersed in the literature and sort of the texts about the field of mental health and psychiatry and psychology. I've been sort of plowing through these different books, looking at the history of our field, because I've come to think that these perspectives are so relevant to the present day. And I'll say a little bit more about that in a minute. I've also, for a long time, been fascinated by history and the history of the field. These are a set of images that I've used before. Just noting that all the world's religions have a form of ritual exorcism. So Christianity, of course, but also Islam, Judaism, just they all had a way of ridding a person who was behaving abnormally of the devil or evil spirits or possession because they didn't know any better about why people were acting peculiarly. Um, this top right-hand picture is bloodletting, and then a picture of trephination to release the pressure on the brain or actually release demons from the brain. And probably both were not remotely therapeutic. And then I think a lot, I have a painting here in my office of Philippe Pinel, who was a physician outside of Paris, who in the 18th century famously ushered in the notion of moral treatment. Rousseau and other French philosophers were talking about the idea that people that were mentally ill should not be out of sight and out of mind, locked up in chains. And so this very dramatic painting is of Pinel ordering that the chains be removed from this woman in a very famous institution called La Sapetière outside of Paris, which is still in existence. But the asylum movement that was meant to be sort of beautiful and sort of philosophically compelling turned out into warehousing. And a lot of what was done in the name of mental health care was a lot of controlling interventions, mostly trying to prevent people from harming themselves and harming each other. But it also really created kind of a dynamic where the perception was, especially around suicide risk, that God gives us life. To take our own life is a sin against God or the king, depending on the period we're talking about. And so the term was in Latin non compos mentis, not in one's right mind. So we have to take control of this person and make them not do self-harm behaviors with the hope of them coming back to sanity, in which case they would no longer be suicidal. And so that's a basic dynamic that we've had for decades, if not centuries, really, when you think about it. Um, they used to electrify the entire body. There were different kinds of surgical techniques. This one picture here in the right-hand bottom corner of this image is William Freeman, who did what's called referred to as ice pick lobotomies. He thought he should receive a Nobel Prize. He would go around the East Coast in a station wagon. He was a professor here in Washington at George Washington University Medical School, and he would line up a dozen patients and then tap an ice pick instrument into the orbit of the eye and then swish around the prefrontal cortex. And lo and behold, there was dramatic behavior change, but probably nothing that we would think of as being therapeutic. But again, at that time, it was seen as a miracle that you could take somebody who was extremely violent and have them transform into a much more passive and peaceful patient on the unit. These are papers that you can't read or images that you can't really understand, but this is the papers I've been writing in the last couple of years about policy, about this history, about this notion of a carceral approach, sort of imprisoning people who are thinking about suicide. And on the bottom row here are various blogs that I do for the Psychology Today website, which you're welcome to check out. And all this is a long-winded way of saying the Joint Commissions actually sort of embraced a lot of the ideas that was in this task force developed by the Action Alliance, in which I served, and identified four sort of low-hanging fruit of things that could and should be done in different kinds of medical settings, including inpatient care. And then a couple of summers ago, this study was conducted by some colleagues and by the Pew Foundation, showing that these simple, low-cost, not labor-intensive things to do were not reliably done, or if they were done, they were not done with adherence. So out of over 22,000 Joint Commission accredited institutions, you had a small sample of those responding. And of those that responded, only 8% did these four simple things: safety planning, warm handoff after outpatient to outpatient care, caring contacts after discharge, and lethal means safety. Even with safety planning at 61%, it was shown that they were not using the safety plan as Barbara Stanley and Greg Brown intended, or similar interventions, which we'll talk about in a minute. So this is abysmal. This is not an opinion. This is data that our inpatient settings are doing a terrible job at doing even these sort of simple interventions in a reliable fashion. Again, this is not meant to just be a wholesale bashing of inpatient care. We can make inpatient care better. But according to this survey, of the people that were willing to respond, this is a pretty abysmal showing. There has been some recent papers coming out about involuntary hospitalization. This one here on the left is a scoping review from Australia that really shows that made for medication compliance, involuntary commitment can be helpful, but with regard to suicide, it is not helpful. There are 5 clear studies showing significant correlations of increased risk following involuntary inpatient admissions, and even a case where all forms of death were increased significantly. Now, correlation doesn't equal causation, but this other paper that came out from the Federal Reserve, the Fed in New York, is also speaking a little more nuanced findings, but similarly rather critical. And what it underscores is that we still really want to believe that making someone not be suicidal or committing them against their will is an acceptable and therapeutic way to go. Now, there is always exceptions. So I'm very prepared for people in the chat to say, but I had a cousin who was committed and it saved their lives. I know that those exceptions exist, but these reviews basically say that the risk is increased significantly and may cause harm. And the lived experience work that we're doing in my lab now, uniformly, without exception, is extraordinarily negative about the involuntary commitment experience. My takeaway is that the whole notion of out of fear, controlling somebody in a carceral model is rooted in a medieval mindset. And hopefully, in 2025, we've gone beyond a medieval approach to this particular challenge. So one good news story has been the Zero Suicide Framework that has been rolled out now for a number of years. However, while we see some really nice publications coming out in the last several years about the effectiveness of the Zero Suicide policy model, I would note and have written about with Julie Goldstein Grummet a failure to really embrace the treat, which is to me the center of the model, to do everything in the front end and everything in the back end, but to sort of skip over what I would say is the most important of the elements of the model, which is actually treat what makes someone consider suicide. So just to kind of march our way through sort of things that are very prominent in the field of clinical suicidology and some of the controversies and some of the evidence about those controversies. One is screening. And the ASQ, in my view, is the best. Now, full disclosure, I'm on the team with Lisa Horowitz in the NIH group that developed the ASQ. From a test construction standpoint, I'm kind of a purist. And I like the way that Lisa developed it, and we helped collect data at Walter Reed for the adult sample and for active duty military. The Columbia Suicide Severity Rating Scale, developed by Kelly Posner and some prominent colleagues in the field, is by far probably the most widely used and recognized of the screeners out there. Kelly retrofitted a tool that was used in FDA trials of SSRIs to a clinical tool, and there have been now many studies on the psychometric stability and reliability of the Columbia. I'm really become more in favor of the SPQR, developed by Osman and some other colleagues. It's a very short screener. It's got really nice psychometrics. I've seen it being used more in research, and it's a nice assessment for both SI and behaviors in adult and adolescent populations. But another widely used screener, and all of these screeners are available on the internet, so they're all free, and that makes them more attractive, is the PHQ-9 is a screener that I think is uniquely problematic. Not as a depression assessment tool, but as an assessment for suicide risk. Now, Greg Simon in the Kaiser system has shown, along with Ursula Whiteside, that this question number 9, thoughts of hurting yourself, thoughts of death or hurting yourself, is an imperfect proxy for suicide ideation, but there is some evidence that it actually can be helpful. However, I did a study with Lisa's group at NIH looking at how many people are missed by the PHQ-9. And because the screener is meant to identify people, I would strongly recommend that you not use the PHQ-9 and use the 3 others here, especially the ASQ, given the psychometrics and that we want to be erring on the side of identifying people and not missing people with our screening tools. Now, I went to the consultation at Fort Hood in Texas, at an Army installation in a war resiliency unit, where a social worker told me that they asked soldiers up to 32 times a week about suicide. That's probably not a great use of assessment, and you probably are not getting what you want. So we have to be thoughtful and realistic about assessment and screening and all the controversies that are connected to it because they're considerable. So what are those controversies? Well, first up, I favor screening because even though there will be some false positives and false negatives, there is a subset of people for whom this really can launch a valuable process of potentially life-saving care. So we can live with some degree of false positives and false negatives. But here's the thing, and this is where being older can make someone get sort of exasperated. I heard George Murphy, who was a psychiatrist in St. Louis back in the 80s, say that we cannot predict future suicidal behavior, but we don't throw the baby out with the bathwater. There are relative differences in people that are suicidal and relative levels of risk. This has been rediscovered in the last several years, and there have been multiple arguments that we can't predict suicide, and so therefore any sort of categorization of low, medium, and high risk is a disaster. But what's interesting in these sharp critiques, these pointed critiques, is no one's really offering an alternative. And when the alternative is offered, it's often a formulation of risk, which my dear friend and colleague Terry Maltzberger was talking about in the 70s and the 80s. So a lot of these things are not new, but the whole idea is that we want to be able to clinically describe differences between different kinds of suicidal states. When I wrote the third edition of the CAMS Guilford Press book, I sized up this whole thing after extensive conversations with David Rudd and Thomas Joyner, Marjan Holloway, Kate Comtois, lots of colleagues about, how do we get out of this, what David Klonsky refers to as the red herring of not being able to predict future suicidal behaviors. And so I really embrace this idea of relative stability because stability can be indexed to imminent danger, which is the medical legal bottom line about what might spur a hospitalization. This has not taken the field over like wildfire, much to my dismay, but I would still insist that relative stability has no illusion about predicting any future behaviors and is a viable way to go. We'll see if it catches on, but it's a way to sort of end run this whole debate. Now, safety plan type interventions were the remedy for no harm contracts, which I grew up with back in the 80s, working in inpatient psychiatry. Of course, the most well-known is the Stanley Brown Safety Plan, shown here on the right. The one in the middle is the Crisis Response Plan developed by David Rudd and then has been elaborately and extensively discussed and studied by Craig Bryan, sorry about that. And Craig has done extensive randomized controlled trials with crisis response planning with some really nice data. In CAMS, we have also, I think, a first cousin of these kind of models. But of course, the stabilization plan in CAMS is embedded within the whole intervention. Here's the takeaway. These interventions are so much better than what I learned, which was a no harm contract. Promise me you won't kill yourself. And if you refuse to promise on my document, then I'm going to have to put you in the hospital, which was invalidating and shaming and coercive and never effective. And now we have randomized controlled trials, especially with the crisis response plan, this one here in the middle, which really has the best evidence. So this is one of those things. The Stanley Brown Safety Plan is like the Band-Aid of bandages for safety plan type interventions. It's by far the most widely used. If we go strictly on randomized controlled trials, the crisis response plan is the most robust and best intervention of this kind. This is a busy slide, but it's also a really important slide because it talks about acute interventions that we can use with people at risk, like the 988 Suicide and Crisis Lifeline, the text line 741, and the use of lethal means access or the CALM approach developed by Kurt Michael and colleagues. These are really important interventions to decrease the lethality of a situation and the acuity of a situation. These are not treatments. So often I hear, well, we did a Stanley Brown safety plan and a Columbia, we're done. That is in the zero suicide model, the first steps. but you're not actually treating the underlying causes of why this person is suicidal. Now, let's take a thought or a moment to think about evidence-based, because apparently everything is evidence-based. But my way of thinking about evidence is really different than maybe sort of the common usage. So, for example, gatekeeper training, I think there's a new, more progressive term for gatekeeper training, but this idea that just ordinary, regular civilian people can be part of the suicide prevention solution is certainly championed by QPR, ASSIST, Sources of Strength, different kinds of trainings that I think are really valuable. But there's an internal validity issue. Most of the evidence in support of these interventions is a pre-post training effect, and we don't necessarily know, does it translate into impacting people that are actually suicidal? So that's an internal validity issue. It's a hard thing to study, I'll grant you that. But when we talk about CAMs or other interventions, we're talking about impacting people that are suicidal directly. Screening is a test construction exercise. I've kind of talked a little bit about this. I'm a big sort of purist about this in the way that you do prospective test construction screening around the psychometrics of these issues. And of course, prediction plagues our field. There are other assessment tools that are actually well test constructed, but they're proprietary, so nobody really uses them. And we know this because we did a survey that cost money. There are interventions that for acute risk, but these are not treatments. I've made that point. I'll probably make it again before we end. And then if we're looking at treatments, which is where we're going next, to really get to empirical validation, you want randomized controlled trials which get into causality. You want replicated findings from RCTs. And then you want other people other than the developer of the trial to find the same RCT findings, and that gets us to empirical validation. But before we get into that, one of the things that I've been really trying to make a big issue about, along with Thomas Joyner and some other close colleagues, is that the field has a behavioral bias, which I get. 11th leading cause of death, almost 49,000 deaths per year, millions of attempts. But what Thomas and I wrote about in this editorial that was one of the top, I think it was the top rated paper in the journal Crisis for the year we published it, is that we have 16.9 million American adults and teens who have serious thoughts of suicide, according to SAMHSA research. That's well over 300 times greater. And we've had papers rejected because CAMs only reduced suicidal ideation when other treatments don't touch ideation, which arguably is the iceberg under the water, with deaths and attempts being the tip. I would argue if we were better at identifying these folks upstream at the ideational level and treating them effectively there, fewer are going to make attempts and fewer would die by suicide. So we've written some papers, several papers actually, looking at suicide ideation. And I talked to Thomas and some other editors. I think we are seeing an increase in research on ideation, which is welcome because it's remarkably understudied. And in my view, it's the biggest challenge we face in the field of suicide prevention, 16.9 million Americans in 2024. Okay, treatments. The treatments that are most effective from RCTs are psychological treatments. There are some promising medications, but really not even approaching. Clozapine, for example, FDA approved based on one randomized controlled trial, CAMS has 7. So we just really would like to find a medication that would do the trick, but nothing's as effective as something like DBT. DBT has the most RCTs. Krista Ku's review, meta-analysis with Kate Comtois in 2019, really shows that it's by far the best treatment for reducing attempt behaviors and self-harm, but it doesn't necessarily reduce suicidal ideation. So there's been a bit of a bifurcation of those treatments that work for reducing attempt behaviors and those treatments that work for ideation. Marcia has been a mentor to me, very generous with me over the years. I really owe much of my research success to her tutelage and her mentorship. I'm very grateful to have known her and worked with her over so many years. Tim Beck, the late Dr. Beck, who developed cognitive therapy, and Greg Brown did this really important study in 2005 called CTSP. It's a suicidal mode treatment, a cognitive behavioral therapy treatment that reduces attempt behaviors by 50% compared to treatment as usual, but doesn't necessarily reduce suicidal ideation. A close cousin is BCBT, developed by David Rudd, and again, further elaborated by Craig Bryan. And Craig and David have really done some excellent research. This is the original study that they did at Fort Carson with soldiers who had been heavily deployed to Iraq and Afghanistan, showing a 60% reduction. There's an important inpatient trial of BCBT, 4 sessions at Yale, showing a nice response at follow-up, both for attempt behaviors and promising data in terms of ideation. And these guys have also developed an app that's under FDA review, and Craig has some initial data about its effectiveness called Aviva. There are other promising treatments. Mineralization-based therapy founded in the UK has not been replicated independently outside, as far as I know, by Bateman and Fonagy. Attachment-based family therapy, Guy Diamond's intervention is looking for a replication outside of his lab. The OSIP intervention, developed by Conor Michel and Anya Geisen-Millard, is an incredible intervention with several randomized controlled trials trying to replicate. One trial that was not supportive, that Anya says has some flaws. These are very difficult and expensive studies to do, and we'll see what the verdict is on OSIP, I think, in the coming year or so. I like Class, built by Evan Miller and my friend Lauren Weinstein. I think they're in various stages of clinical trials. And then I'm just super excited. Kate Comtois has been a close collaborator, the PI or co-PI on 3 of our CAMS RCTs. She is the PI of a P50 at University of Washington, and she's developing a primary care intervention called Connections Intervention, and a consultant to this. It embraces really the spirit and the ideas of ASHI. There's a lot of CAMS in there, there's a lot of BBT in there, but Kate is certainly qualified to develop a more sort of clinic-based behavioral intervention in primary care, and that's where we'll see some developments in the coming years. Of course, my bias would be for CAMS. I'm not going to do a detailed review of CAMS. We have the training website and CAMS Care to do that. I'll simply say it's a therapeutic framework where we emphasize empathy, collaboration, honesty, and we're focused on suicide. A novel thing about CAMS is that we take a side-by-side seating arrangement to really work through a tool called the Suicide Status Form. There's the roadmap of assessment and treatment planning. The patient fills out certain portions, the clinician fills out certain portions. This becomes the medical record, and we also always give patients a copy of their SSF at every phase of care. The first phase are these 4 pages. The second phase is interim care that begins with the core assessment. We have a stabilization plan that we further craft, and then we treat drivers. And this is a novel thing about CAMS. What the patient says makes them consider suicide. And that's what we target and treat in CAMS, using whatever interventions make sense. We have certain criteria for outcome and disposition, and that marks the end of CAMS. And that documentation is crucial because it decreases liability. It also becomes a reference point. We just resolved a case in our adolescent trial right before this presentation today, and the clinician went over all the SSFs for the 8 sessions that he did with this 14-year-old, a really successful outcome case. So these documents really are accessible to the patient, and they really do kind of guide the patient on how to use their stabilization plan and how we're going to be treating their drivers. COVID comes along, we can't sit next to patients, so we flipped and got Guilford Press to agree to support installing this. Andrew Evans, the president of CAMS Care, has been the lead on really making sure that we're in with the big EMRs. And you can do DoxyMe or Zoom in a HIPAA secure platform, and then do the SSF for the patient, and the patient can correct you. And I don't think we've lost any of the empathy or collaboration that we see in sort of the standard CAMS administration. So adherence to CAMS is what my lab does. We do training, and then we watch videos for fidelity and adherence purposes. We use the CAMS rating scale to make sure that the philosophy of care is being embraced and that they're doing the therapeutic framework as we would have them do. But within that framework, there's a lot of individualized flexibility that clinicians can use the techniques that they like to use, and they can sort of do this in the way they want to do it and still be adherent to the model. I'm excited that there are papers now being written. This is a paper out of Finland by a colleague talking about self-determination theory in CAMS, which is a really cool paper to come across. Here's a paper on motivational interviewing. Here's a paper in The Lancet by Keith Houghton and Mort Silberman that totally embraces sort of the key ideas that we see in the CAMS framework. There are now 13 open correlational trials. The stars have comparison control groups, but were not randomized. The 2 most recent trials that I'm aware of, one that got published in Crisis in the UK, in the National Health Service there, of inpatients and outpatients, really nice feasibility trial. And a new trial in Greenland, where a prospective RCT is now being planned. This really helped us turn a corner. It's a meta-analysis of 9 CAMS trials. The square highlights the significant findings in comparison to control care. The arrows all speak to trends in the effectiveness of CAMS as well. The biggest effect for CAMS is on decreasing hopelessness and increasing hope. What we always find in our RCTs is that CAMS reliably reduces suicidal ideation, overall misery, and treatment acceptability is almost always significant. The big criticism of CAMS, you see it here, is that attempts is just a trending effect. This diamond is not exactly on the line, but it's not a significant effect like you would see here for hopelessness. So the criticism is that CAMS doesn't reduce attempt behaviors or self-harm. There was one sort of conflicting mixed findings in a Danish trial. But this German trial of an inpatient use of CAMS clearly showed a signal, a significant finding for decreasing attempt behaviors at 1 month post-discharge, which is a really high-risk period. And so that's a welcome finding. Of course, we want to replicate those data, and we have some embargo data I can't really talk about that I think will provide that replication. So these are the 7 randomized controlled trials that support CAMS, the most recent being the Santal trial, an inpatient use of CAMS uh, versus a very good control condition, a cognitive therapy intervention that did give us a signal for post-suicide attempts discharge. And there are now several RCTs developing in China. I think maybe 2 in China, 1 in Australia, this new one in Greenland, and then a multi-site European study that my friend Maurizio Pampelli is doing out of Rome, Italy. So these are the ongoing trials, a campus trial with college students at 4 university counseling centers across the nation. We're using AI in this trial to identify what treatment as usual is. That's kind of been a black box up to now, but now we have a really cool AI program that's going to help us define what treatment as usual actually is. A clinical trial that we did at the San Diego VA in California. These data are currently being analyzed with Colin Depp as the PI. 2 trials at the Cleveland Clinic and Mass General, and 1 at Seattle and Nationwide Hospital in Columbus, Ohio, for teens. 1 is a ketamine trial compared to saline with patients getting CAMs before discharge from inpatient care. Then this really cool and robust trial that Molly Adrian is the PI on. The PIs for that are Amit Anand and Tatiana Falcone. For the Cancer Teens trial, we're looking at Jeff Bridge and Molly Adrian, who is the PI, and Greg Brown, Barbara Stanley, who passed away several years ago, Elizabeth McCauley, are all involved in this trial. We developed something called the Stabilization Support Plan, which you can't see here, but it's been a really cool intervention for caregivers and parents to support their child in the course of their treatment. This is a new, well, it's not new. We've been doing 2 years of feasibility, but the launch of Intent to Treat is now underway. It's a PCORI trial looking at electroconvulsive therapy versus IV ketamine for acutely suicidal inpatient adults. Everybody after those somatic treatments gets their first session of CAMS before discharge and 7 sessions post-discharge. So this will be the next 5 years. It's a monster trial. Amit Anand is the PI for this rather large and ambitious endeavor. Really excited about this. This is a 1 session use of CAMS that I first theorized, but Ray Tucker actually put into action. Nick Oakey Frost is the student that really put this on the map with a study they did at Our Lady of the Lake in Baton Rouge, showing that 1 session of CAMS can reduce symptom distress, but also increase motivation to live. This is now being replicated in a number of clinics, and especially children's hospitals, where we want to see this 1 session intervention work like we hope it does. It did it in the LSU study. Empath units, here's my other hero. There's Philippe Pinel, and then here's Scott Zeller, who is an emergency psychiatrist that developed the notion of an empath unit. Empath units are meant to be the remedy for chaotic emergency departments. And we just were at the Empath Summit, the first ever in Dallas in May, talking about how this more comfortable environment that can help people calm and soothe themselves could be really supplemented by CAMS brief intervention. Because over 70% of the patients in the empath unit or EDs are suicidal, the idea of using CAMS brief intervention in a non-chaotic ED environment is a really compelling notion. We're doing a lot of training to this end. So there are benefits for hospitals, for clinicians, and for patients who suffer. Clinicians actually are really excited because they're actually doing something that feels effective. We replicated the CAMS BI model at Children's Hospital of Atlanta. This is Morgan Reed, a former student here at Catholic, and a current student, Francesca Fernandez. This is Sean Joe's group that we've been working with for a number of years. Sean and I are reconnecting on this, but Amy Brausch has been a key collaborator, and we'll be replicating the psychometric study that Amy did in Kentucky on the SSF with more underserved populations. This study that Morgan and Frenchie did in CHOA in Atlanta, 7% of the teenagers were persons of color. We're going to get final data in November, but the caregivers were really also really benefited from the stabilization support plan in this trial. Super excited about this is Tatiana Falcone, who's an attending psychiatrist. She's an adolescent and child psychiatrist at the Cleveland Clinic. She got a grant from the MQ Foundation to put teenagers in a MEG and fMRI machine to get sort of baseline imagery for then CAMS for teens and then post-discharge. She's really interested in the development, the neuroscience of hope, which is a big interest of mine as well. And we're excited for this grant to proceed in the coming years at the clinic. She also put in for a CAMS brief interventions versus Stanley Brown safety plan randomized controlled trial. I think this will get funded and it'll be a super exciting study for us to pursue. Getting down to it, this is the Hope Institute model developed by Dr. Derek Lee. Derek is a licensed professional counselor and a colleague at Perrysburg, Ohio, who developed the first Hope Institute. All they do is CAMS, and they also add DBT skills. And what Derek has found is that we can stabilize adults and kids in 5 to 6 weeks, avert ED visits, and avert inpatient care, saving tremendous amounts of money, healthcare dollars, by doing effective evidence-based care. There is now a Hope Institute in the Chandler School District, one in Atlanta Children's Hospital, one in Boulder, and a new one is being stood up in Portland, Oregon. This is a really compelling model. There's a lot of interest in this. Of course, reimbursements is sort of the battle at the end of the day. Can we actually get the payers to pay to make this an economically viable model? So we're at it, and we'll see how things play out in the next several years. Of course, this company that's bringing you this webinar, we train people in CAMS, and what I'm really compelled by in sharing this is that we know that CAMS now in 3 published studies increases provider confidence. So to kind of loop back where I started, this is an issue clinically presentation-wise where clinicians want to get rid of these patients. Patients sense that, and it's not therapeutic. But if we have clinicians who feel confident, I've got this, we're going to help you. This helps people. The evidence is robust and clear. It's going to be okay. That creates a placebo effect in the best sense. It says this person knows what they're doing. That gives me a sense of hope. If my clinician knows what to do, they're not trying to get rid of me, they're actually doing something that's effective, that gives me reason to feel like I'm glad I came in and there's a reason to hope. So the way forward, we must move away from a carceral approach that focuses too much on inpatient care. And inpatient care can be much more evidence-based. They can do CAMS inpatient or use the BCBT inpatient model if you insist on hospitalization. We must embrace evidence-based treatments and become more outpatient-focused. Clinicians need to improve their confidence, and we know that we train people in things that work, they can become more confident, and we need more clinicians to seek out this kind of training. Tort reform could help with malpractice. A lot of clinicians do defensive practice because they're afraid of malpractice litigation. DSM and ICD diagnoses for suicide risk could be helpful. Igor Galinker, Thomas Troyer have been working on that front. Insurance reimbursements for evidence-based approaches, for example, phone coaching and DBT should be reimbursed by insurance. It's really a key element of what makes DBT successful. And improving healthcare plans for cost-effective reimbursements that are cost-effective, least restrictive, and evidence-based is really needed to decrease the suffering of people that are suicidal and to help save lives clinically. So this is the lab at Catholic U and all the people that make this happen. I'm so grateful to these students who really do make the world go round. I'm grateful to CAMSCare, Kevin, and all the support staff and all the consultants. Andrew, who's the president of CAMSCare, is a fearless leader in sort of trying to get the word out and scale our intervention. And my wife, Colleen, who's pretty much at the heart of my professional success and also my personal happiness, who's also our advocate for advocacy and awareness as part of CAMSCare. So with that, I will stop and we'll take some questions and some comments with Kevin's help.
Hey, thanks so much, Dave. That was great. All right, so just up front, logistically, we had a lot of questions come through from people around, can you get a certificate of attendance? Unfortunately, we don't provide that. but we do want to be able to give resources as requested. Dave, one of the things I'd like to work with you on after the fact, if that's okay, is you may already have a resource list in the slides, but we have a lot of questions from people around. Can we point in the direction of specific citations? And maybe we can even on the CAMSCare side make those available on our site
Sure.
so people could just download
Absolutely.
the article.
Yeah,
So for everyone interested,
this recording will be on the website and a PDF of my slides will be on there, but we can create those resources as well on the website.
that's perfect. All right, so there were a few questions that came up, and please do feel free if you have questions now to throw some in. I'll try to get to as many as we can and to blend a few so that we can knock out maybe three or four in one. There were a couple around hospitalization I'd like to start out with, Dave, though, in terms of some people spoke to it's really tricky on their unit to be able to follow up with patients once they leave. They're actually kind of told that it's unethical. And there's some kinds of big myths that they go in. If you wanted someone walking out of here with the biggest fact of inpatient care and what would make it better, what would you want people walking out of here with?
Well, that the Joint Commission study, they would actually get a safety plan, some kind of safety plan intervention. There would actually be a discussion about lethal means safety, especially if there's a firearm in the home in the United States. That's our number one method choice. That there be some kind of care and contact or follow-up. I teach ethics. I've published a bunch of papers and book chapters on ethics. It is not unethical to do follow-up. You have to get informed consent, and there are considerations around HIPAA and so forth. But we know that caring contacts and follow-up are effective. It's an effective intervention at the world level. Kate Comtois and others have shown that caring contacts and follow-up in different modalities can make a difference. So I hear the yes buts all the time that we can't do this. You can. And I hear all the time that, well, we have to commit patients against their will if they're suicidal. It's the law. You're asking me to break the law. It's actually not the law. The law is that there's imminent danger, but actually the imminent danger term is not well defined on the judicial side or on the legal side, nor on the clinical side. I had a student who was a master's student in psychology, who was also getting a law degree here at Catholic, who found 62 different definitions in the legal and psychiatric and psychological literature with crazy wild, like from a year out to like 15 minutes. I would say imminent danger is that there's going to be there's going to be an event within the next 24 hours. But even there, if lethal means have been made secure, you can still work safely with a person on an outpatient basis. Are there exceptions? Of course there are. I'm aware of a case of a person who was homicidal, had homicidal fantasies, and was a very dangerous kind of person that really should be in the hospital and should not be allowed to leave AMA. But there are the vast majority of people, I would say, in my experience, it could be handled effectively on an outpatient basis. So there are people doing the things I'm describing. It's not like a pipe dream, but you have to change policy. You have to talk to your attorneys. A lot of times, general counsels are good people to talk to because they care about liability and the threat of malpractice litigation. There are very important things that you can do that I've described that are going to actually decrease your liability, especially if it's well documented.
So along those lines, we had quite a few questions come in around certain interventions that you mentioned. Safety planning broadly defined, right? The SPI, crisis response planning, CAM stabilization plan, and caring contacts. So I think I'll lump these together and say if somebody is looking to say, what's the difference between a good and a bad safety plan or a good and a bad caring contact? What are the big
Yeah,
points we should take away?
for safety plan type interventions that they're done collaboratively. So a lot of times we know from the Pew study that the safety plan is just handed out by a nurse and it's filled out by a patient in the waiting room or in their bedroom and handed back. That is not how Barbara Stanley and Greg Brown ever wanted the safety plan to be used. Craig Bryan and David Rudd, who use the crisis response plan, will actually have the patient, write down on an index card. And we know that writing is different encoding, different retrieval, and they'll laminate that card and keep it in the patient's pocket. So it's meant to really be something that we're working on together to get you through your dark moments. One of the big challenges that Matt Nock at Harvard has a whole P50 around is people forgetting to use their safety plan intervention. We're thinking about using hypnosis and post-traumatic suggestion in a study here at Catholic to get people to remember that when you feel this way, that's when you know, choose your stabilization plan. In terms of caring contacts, what the research shows is that if someone that this person actually spoke to is following up with them, the original study by Jeremiah was a letter, but also with texts or phone calls. There's been some mixed data, but I think the bulk of the research shows that following up with somebody and saying, "How you doing, Kevin? It's been about a week since you've been here at the hospital. Hope you're doing well. Did you make your appointment with your psychiatrist? Is there anything we can do to help facilitate that?" That actually makes a difference in terms of behaviors and not just stabilizing people post-discharge.
Let's shift, if you don't mind, a little bit to another topic, right? One of the next ones that came up that we talked about was screening. And so here's a question that I think summarizes stuff very well in terms of things I picked from the chat.
Yeah,
What are your thoughts on the frequency of universal screening as healthcare is doing it? Does the frequency impact the honesty of results? Do patients get frustrated with this?
of
How should
course I
we do
do.
screening in a way that aligns with patients and
Yeah,
clients?
of course it does. I mean, that's why my Fort Hood example of 32 assessments in the week is ridiculous. I feel somewhat mixed about universal screening. I do not feel mixed about a population who might be more at risk or a mental health population. But I just know for a fact, I have anecdotal cases, but also there's evidence I mean, Craig Bryan and others have taken issue. There was a academy, I can't remember, it was a child academy that was like it's discouraging screening of kids. I just am pretty clear that there's a subset of people that actually want to be picked up by a screener. I am certainly aware that people lie. I'm certainly aware that people exaggerate, but I just don't feel like the argument that screeners are bad and should never happen holds water. The frequency I think does matter, and I think it's got to be reasonable. That's why I had in that slide. We got to be thoughtful about what this can and can't do. And really, any screening is better than no screening, in my view. But that's where the screener that you use actually matters. The PHQ just misses too many people. It's a great tool for depression, but it should not be used, in my view, for suicide screening.
And then a specific subset of this, we had a question around crisis co-responding clinicians. So clinicians in the field going on, navigating screening and very quick assessments, very quick
Yeah,
interventions.
yeah.
What's best practice considerations in that context?
I mean, CAMS-BI, you look at the study that Ray and Nick did at Our Lady of the Lake, that was in a chaotic ED and also in inpatient care and primary care. 100% of that was done by graduate students. 100%. People that Ray trained and supervised. So you're basically tripling the documentation, which is going to decrease your liability. And you had patients in that study, 40% of those patients were committed against their will. And a large percentage of them were African American, is an understudied population, as I mentioned earlier. So the fact that they got that kind of signal in one session done by graduate students in training, it addresses a huge workforce issue that we need more clinical providers. You don't have to have a PhD or an MD or an master's degree if you're well trained and well supervised to do a potentially really meaningful intervention with one session that decreases your liability and that patient's like. Nick Oki-Frost went off to his internship, brought CAMS-BI with him, saw a patient on his first weeks of his internship, and the patient came out and saw his attending psychiatrist, said, "This intervention this guy did with me, I've been coming here 30 years. I got more out of this one-time intervention with this guy than I've had in all the years I've been here." Nick is like, "Yeah, that was me." So, it doesn't always go that way, but it's nice to see something having landing and having that kind of impact in one session.
So when we think about this information so far, and I think this question also nets treatment too, but the hospital stuff, screening, the challenges of prevention versus treatment, there's a question around, does all of this equally apply to adolescents and kids? Is
We
this
don't,
universal?
yeah, we don't know. I mean, that's why NIMH has been pushing to fund more adolescent studies. That's why we really leaned into the adolescent population. There's even less known about children. We were heading full speed towards children, and then realized we got to really figure things out with the kids. And what I will say about the adolescents, just got off a consultation call, have had numerous experiences where the parents, out of their fear, really can sometimes make things worse. And I say this as a parent, and I say this as a clinician, and as a person of who's concerned about this, that out of fear, sometimes parents will just immediately take the child to the ED or an inpatient unit. Ava Sis at the University of Michigan published a paper with Cheryl King's lab showing that a second hospitalization is significantly associated with a much more severe trajectory of suicide risk and increased attempt behaviors, second hospitalization. Cheryl told me they went through four, maybe five revisions to publish this paper. The data is rock solid. The reviewers didn't want to believe it. What's happening in an inpatient unit? They're getting medication, which is not especially effective for kids. They're in some groups that research shows are not particularly popular or found very helpful. They're not doing some of the basic things, according to that Pew study, that could actually make a difference. So we just have to improve inpatient care. It's not that it's bad, it's just not evidence-based. It relies on a medical model, and I think in many ways the medical model doesn't hold up well when we're talking about ideation and behaviors. Really, all the evidence that, the heavy evidence is in support of psychological treatments. The exception might be lithium carbonate for bipolar disorder. Clozapine and lithium are probably good treatments. And we have IV ketamine, which has an effect about half the time. It's an emergent effect, and it stabilizes people. That's why the funders are excited to have people have a response therapeutically to ketamine and get CAMs on board, like with adolescents. The problem in the teenage trial is that Matthew Perry's overdose on ketamine has really hurt the ketamine research business, I gotta say. And also, a lot of the adolescents in that Cleveland Clinic sample are needle phobics. So they don't want to get an IV infusion of ketamine or saline, which is the experiment. So we've really had some challenges with the administration. There's S-ketamine, which is administered nasally. I'm not sure that the S-ketamine data is as robust as the IV ketamine, but we just want a drug when the evidence is so clearly supportive of these psychological treatments that clinicians typically don't know.
Hmm. All right, a couple of treatment questions then if we sort of spin off of that into some more broad considerations.
Sure.
If you could revamp graduate school classes and make sure that everybody came out with a couple of foundational points around treatment, right? Not just the hospital piece, but what do I do in the room with a patient? What do you think every student should know or every clinician should know?
Well, they should certainly know about assessment and the screenings that I talked about. They should certainly know about the acute interventions. There's no patient that shouldn't at least get 988, the national text line, a discussion about lethal means safety in the home, and ideally have some caring contact and some support by the caregivers in their life. They should know that there are treatments, the ones I've described to you, that are available, and they should, I'd arguably get exposed. I did a training here at Catholic U a few weeks ago of our counseling center staff and the members of my lab. We trained 36 people. The role play training that we do as part of our integrated model. I mean, ideally, that's what they should get, or they should get that, in terms of BCBT or CTSP or OSIP or, one of these evidence-based interventions. It's a really tough sell. And a lot of people just prefer to get rid of patients and put them in the hospital for 3 or 4, maybe great insurance, maybe 5 or 6, 7 days, where there's no evidence-based treatment typically going on. And then we know that people come out of the hospital at increased risk. That's not an opinion. That data has been replicated around the world and it's been around for a while now. I think it's because people get the Cadillac of inpatient care, tens of thousands of dollars of care, and it didn't help. And sometimes they feel worse coming out of the hospital than even before they went in, which is not the point. And if people, the Psychology Today blog I wrote, is like, if people still insist on an inpatient model, then at least we should do what they did in Germany in that trial. They used CAMS, an inpatient unit, or the BCBT trial, 4 sessions with great outcomes. But that still is a tough sell, and it shouldn't be because it is evidence-based, it is effective, it's going to decrease your liability, and it actually helps people. And that kind of gets lost in the sauce. People are suffering. How is it that a paper that we submitted got rejected because CAMS only reduced ideation? That's nuts. So we really need to sort of take out the lens and say there's a lot of people who are suffering. We really do need moral treatment. And that is not about locking people up. It's about giving them treatment to help them with their suffering.
And then on that treatment piece, if you were to reflect on the state of data right now, and you were to say, I have this client, how do I know if DBT might be the best fit or BCBT, CTSP, or CAMS? What would you consider based on the data available?
Well, we're really actually studying that. As you know, Kim, we have a smart design, for example, in the campus trial where they get CAMS versus treatment as usual, or more CAMS or DBT skills group. What I would say is that if somebody is new to being suicidal and is sort of laden with suicidal thoughts but has no attempt history, CAMS, no question about it. They're going to respond in 6 or 8 sessions. There's no question about it. And I'm being biased. It's just so clear. If there's a multiple attempt history to a more a chronicity, maybe some personality disorder traits on board, and a person is comforted by thinking about suicide, that's a different person. That's probably somebody who really could benefit from DBT. But DBT is more than just skills. It's a full intensive program with group, individual, phone coaching, and that's a lot to learn and a lot to do. I think BCBT and CTSP clearly for people that are attempters at high risk, it's going to decrease their attempt behaviors. One of the things that we're learning from our lived experience research is, and these are people that have been suicidal, is they're saying, why does it feel so hung up on my future attempt behaviors? I'm suffering now. Why aren't you guys more focused on that? And cans we are, but it really to me that editorial that Thomas and I wrote was it was the best. It was the number one cited paper in Crisis that year, and there's a reason because people are like, oh yeah, ideation really does matter. And by definition, we don't call a death a suicide unless there is ideation on board. Otherwise, it's an accidental death. So to reframe that and sort of say we should bring much more attention to the ideation challenge, I think is obvious. Um, but people are interesting and our field is funny and a lot of what we are fighting is we've always done it this way. We have to do it this way. No, you don't. You can actually do things that are effective that patients like, and that will actually help them decrease their suffering and potentially save their lives.
That's a fabulous answer. Well, so we're almost at time. I'd love to
Yep,
ask you one more as sort of a wrap up, sort of
sure.
I think you wove things together very well throughout the questions. But if there were somebody on the fence or somebody who was like, well, what's the big thing I should take away from today? What's the big message that I should take and tell my colleagues? What would you want them walking out with?
Well, 60,900,000 American adults and teens, when asked by SAMHSA in their survey, said, I've had serious thoughts of suicide in the last 30 days. That is the population of Manhattan doubled. It's so many people who are suffering and struggling. What they're struggling with is a treatable phenomenon. They're struggling with thoughts that I should terminate my existence because I can't bear to live. And we have treatments that are effective. I'll just end with this thought. In psychology, the number one journal is the American Psychologist. And I wrote a paper with Jeff Barnett, who's an ethicist expert at Loyola University. And all we said was, we're ethical psychologists. We should do things that are actually proven to be effective. And there's a number of things that I've described in this presentation that are proven to be effective. We should do them. That was the gist of the article. And I fully expected, honestly, I'm not being immodest here. I fully expected desk rejection. Not only was it not desk rejected, we got a spectacular review and it was published. I share that not to brag, but to say the field is actually, I think, primed for some of these changes, but we've got hundreds of years of tradition to overcome to actually embrace evidence-based practices to decrease suffering and help save some lives. And that's what I want people to take away. These are treatable conditions. Clinicians are expected to know how to treat them. A carceral approach that locks people up and does not provide treatments that are effective is not really what we should be doing. But it's a hard thing to change. And we at CAMS Care and other colleagues around the field are really doing our best to try and make those changes.
That's fantastic. Dave, thank you so much. The compliments are already coming in, people finding this very helpful. And I hope you did. We had a few hundred people on the line. I hope you found more than a few things to take away. Just to wrap up with some quick logistics, again, we'll make this available on our website, cams-care.com, pretty soon, maybe by the end of the week.
Yep.
We'll work to make resources available, including some of the articles. I'm very glad that there are so many people interested in picking up the articles in addition to the slides. We'll make that available, and we'd be very happy to help answer questions or address anything else that comes up. But Dave, thank you.